into this follow-up session with David Mealy. And I'm going to turn it over to David now to answer some of the questions that came in. I just want to also remind you about the next session, which is going to deal with challenging cases that people submit. So please submit to us, and David will tell you more about the process and what he's looking for. Some cases that have been challenging where you had someone and you really don't know how to get them to be on track where you want them, or what a number of programs are doing is kind of what they call social autopsies, but looking at cases that people resulted in people terminating from the drug court for whatever reason, and looking back to see could anything have been done. So with that, I'm going to turn it over to David, and thank you, David.
Thank you, Carolyn. Just to follow up on what Carolyn was talking about, that this is the session that's on March 29 at 1 p.m. Eastern Time. And we don't need you to have a long case study where you have to outline every detail. It may be that you have some various vignettes that illustrate a certain point. And this can come from both either the court team side or the treatment team side. Anybody who has some examples perhaps of clients where you felt this is a repetitive issue that comes up and is a problem. So say, for example, on the court team, you find that the update reports or the treatment provider information that's presented isn't satisfactory to you. And if you have some examples of that you would like to discuss and say, here's the report we got, here's the kind of information we get, we find this not as helpful as it could be, let's sort of hear about that and try to discuss it. Or in the opposite direction, there may be treatment providers who say, we have a client who got a positive drug screen and that triggered a sanction, and yet we felt the person was doing well, and that this was a learning opportunity in their treatment plan, and we want to know how we could work together to keep the person engaged in treatment. Or there may be one particular participant or case that, as Carolyn was saying, didn't do well, and we want to retrospectively take a look at what could have been done differently to learn from it. So I'd encourage you all to be thinking about some of these things, and you'll be getting notification about how to submit those. But that's the kind of thing we're looking for March 29 to try to make these concepts more concrete. Now, in the meantime, I'm going to we added some slides towards the end of this PowerPoint presentation, and we'll get to the questions, and I have some sample treatment plan strategies and one sample treatment plan and some other resources to help you. But just to quickly get us in context, especially if you weren't on the webinar yesterday, that this is all about contrasting compliance with court orders to adherence to treatment, which is focused on doing change and doing real functional improvement versus compliance with court orders, which can encourage doing time. And to get the kinds of outcomes we all want, we're really talking about how do we work together to make the phases that are often time-based more milestones around function and change. And we'll go much more into how to engage participants in a self-change process in the webinar on Monday, April 4 at 1 p.m. Eastern, where we'll go into more detail. I'm going to skip forward now to the slides towards the end of this presentation to the questions, a couple of questions that did come in, and answer those. And then I want to show you some resources that you can read some more about this, and then we'll talk about some sample treatment plans and strategies. And in the meantime, of course, please write any questions or comments or disagreements that you might have so that we can discuss those as well. So this is one question that came from a county drug court counselor. How do we handle the polarity of the concrete nature of the law and the court system with the subjective nature of treatment. For example, looking at black and white thinking. A lot of clients have black and white thinking, which can align with the legal aspect of the courts, but this provides a barrier in treatment, especially since in the case of drug court, the two are so closely related that treatment and court orders are so closely aligned. Well, this addresses the issue that when we talk about black and white thinking, it is appropriate for the court mission, for criminal justice mission, to be black and white, to talk about, as we said, consequences, compliance, and control, because it's like the military. You can't have soldiers sort of taking orders from their superiors to say, oh, we're going to attack this enemy, and then have everybody be discussing whether they agree with the decision or not. So in situations of criminal justice, it is appropriate for there to be consequences if people are not compliant with the law, because we're trying to control public safety. So that black and white thinking is consistent with the mission of criminal justice. The issue that comes up, though, is that when we are then saying that people are threatening public safety and increasing crime, and we think it's because they have an illness of addiction or mental health or both, and that's the reason they are offending, and that therefore, to make sure that we increase public safety, we want to treat those people, not just lock them up. And we know how many people are in prison where a lot of their problems may be caused by the fact that they have addiction and mental health. So when we then say, let's give them a chance at treatment, we have to give them a chance at treatment. And treatment is not black and white, meaning that we have to do an individualized treatment plan based on that person's assessment. Now, it isn't as subjective as you might think. We increasingly, in the treatment side, have to become more objective about whether people are improving in their outcomes as well. It shouldn't be just the old gut, well, I think this person's doing well, so let's continue. We want to be able to see change in behavior, change in thinking, change in attitude, change in what they are doing. And that's where the 6 assessment dimensions of the ASAM criteria come in, because you can see if somebody is getting better in terms of withdrawal, if they're getting better in their physical health, whether they're getting better in their mental health, whether their attitudes and their stage of change is improving in the direction of pro-social change. We can tell on dimension 5 whether people are able to cope with cravings to use and are actually not using. We can measure through drug screens and so forth whether their treatment is improving. And we can measure in recovery environment, what are they doing with their friends? How are they changing their friends? How are they changing their leisure activities? Who are the people they hang out with? What sort of recovery support networks and groups do they have? If they are involved with 12-step groups, are they working actively through that? So treatment doesn't have to be subjective and squishy. It can be objective and measuring real change, and that's where the two come together, because the court rightfully wants to know, is this person improving in a public safety way? And the sorts of reports we should be giving them is a direct focus on what are the problems in the assessment we have identified that threaten the public safety, and what are the thinking and behavior and social and skill behavior changes that we can expect to see this person work on in treatment, so that we can report on whether they are actually changing. So getting back to the question, how do we handle that polarity? By saying that an offender, a participant in drug court, has agreed to the mandate from the court to do treatment, and that treatment has agreed to provide treatment, and any time that the participant in drug court is in treatment and is not adherent to treatment, and that means adherent to the individualized treatment plan developed through an assessment and collaboration with the client, anytime they are not in good faith moving in a positive direction on their treatment plan, then they would be out of compliance with the court mandate for treatment, and a report to court would then indicate that this person is out of compliance with the court order because they're not doing treatment. And then that should trigger a sanction, not for positive drug screens or poor treatment outcomes, but because of poor investment in treatment and lack of good faith in doing treatment. So there really isn't a discrepancy in missions. We want to assure the court that this person is doing treatment and is compliant with the court's mandate to do treatment. But the way we do that is to figure out whether they're adherent to treatment and whether they're working actively on their individualized treatment plan and are actually changing. I hope that clarifies it, but please come back at me if that's still unclear from anybody or the questioner if they're on the call. Let's go to the second question, which was from an executive director of a treatment program, and said, what type of graduating sanctions are recommended to help ensure engagement? You can't treat somebody if they don't come. So the way I read that question is that there have to be some consequences if a person's not following through with treatment and is not engaging in treatment. Because if they're not engaged in treatment, they can't really change, and you can't really treat somebody if they don't attend. And that's correct. If somebody says, I'm agreeing to treatment, and then they don't attend, obviously that is non-compliant with the court order for treatment and would be reported as such, that this person isn't attending, they haven't followed through, or they're coming every other session, or they haven't even followed through with meeting some of the simplest of obligations of doing a full assessment and so forth. And then they would be sanctioned because of their out of compliance with the court order to have an assessment and to do treatment. On the other hand, if somebody is in treatment and they are progressing in their treatment, but they're not perfect, they still have a lot of ambivalence about whether they have addiction problems, they still have a lot of ambivalence about whether they want to give up all their friends, they have ambivalence about recovery groups like AA or other support groups, they shouldn't be sanctioned for that because that's a treatment issue. And a good treatment program would be working with those in the treatment plan. So I agree that there should be sanctions if a person is not in good faith doing treatment or not even showing up, but there shouldn't be sanctions for poor outcomes, meaning that they're not doing as well as we'd like them to do. All that would trigger is a reassessment and changing the treatment plan and trying to improve treatment so that the person can have a chance at a better outcome. Now, in the session yesterday, there were some questions about, sample treatment plans, and I want you to know about resources that you can go to my free monthly e-newsletter called Tips and Topics, that if you'd like to subscribe to that, you can go to tipsandtopics.com and subscribe. There's a button on the right-hand side. And I gave you here some past editions, July 2015, March 2006, February 2013, and that should be September 2014, where there are some further information in the February 2013 one on how to help therapeutic communities become more focused on behavior change and not to get into punishing people for breaking rules and to keep it focused more on treatment improvement. And then a bit more on sanctions. That was in the September 2014. In this July 2015 edition, amongst other things in that edition, I did have a list of treatment plan strategies. And here are some examples of treatment plan strategies, and we'll talk more about this in the April 4 seminar on engaging participants in a self-change process, but you'll see there D/D. What that's referring to is discovery dropout treatment, discovery dropout prevention treatment versus RR, recovery relapse prevention treatment. And this is to do with working with people who are not yet embracing the need for full abstinence and recovery. So a proximal sort of goal might not be abstinence and total recovery. That's a distal goal that we would want to have for them, and that should be the result of treatment. But we want people to be honest. So if a person comes in for an assessment, we don't want them to just say the right things, oh, my life's out of control and I want to be totally abstinent, I'll do whatever it takes, when they're actually thinking, I'm just saying that because I want to graduate from drug court and have you hear whatever you think you want me to hear, want me to say. So we'll talk more about the difference between discovery dropout prevention treatment and recovery relapse prevention treatment. But these would be examples of strategies in a treatment plan where a person is not even sure they have a problem, and it might be list 3 reasons the court sent you to treatment. And that would get them to dig more deeply, individually and in group and with their counselor about, well, what was I doing that made the court think I have an addiction problem or a mental health problem or both, which if I got treatment for would increase the chance for better public safety. Another strategy, write down the most recent incidents involving alcohol or other drugs. So some clients say things like, well, I don't really have a problem, I was just set up, I was just framed, I was in the wrong place at the wrong time. Well, let's get specific. Let's take a look at your record and see what exactly happened. And that can sometimes raise consciousness to there being more of a problem than they thought, instead of just projecting the blame on other people. Third strategy, identify what happens if you don't comply with probation requirements and report to group. So this is to increase the awareness of the person. You can do whatever you want to do, but are you prepared to take the consequences if you don't comply with probation requirements? Another discovery dropout prevention strategy, we list the positive and negative aspects of substance use. And you'll notice that it says the positive aspects of substance use, not just the negative aspects. If you always start off in treatment as if the person's interested in relapse prevention and sees that there are totally negative aspects of their substance use, that is where you'd like them to be, but they may actually honestly still think it's quite fine to keep using. In fact, when you take a history of substance use, it's best to ask things like, tell me your top three favorite drugs and what you like about them, not tell me why you want to stop and all the bad things drugs have done to your life. That they may not even agree with that, and yet if you set it up that they've got to try to say the right thing, then we're not going to create an honest assessment. So it's list the positive and negative aspects of substance use. And somebody says it helps me with my stress, and it relaxes me, and it makes me the life of the party, and I feel more powerful when I'm using, then that's an important thing to know, because we're going to have to help them to discover that the negatives outweigh the positives if we're ever going to get them to move in the direction of sustained abstinence and recovery. Another strategy, attend at least one AA meeting and see if you can identify with anyone's story. So rather than mandating 90 meetings in 90 days for somebody who's very ambivalent about AA, a motivational strategy would be, well, at least attend one, and let's talk about whether you could find anybody you could identify with. In group, verbalize what things need to change in your life or not. Again, it gives permission for people to say, I don't think anything needs to change, I'm doing fine. In group, no, discuss the positive and negative consequences of continual substance use. Again, giving them the opportunity to say, you know, I don't see anything wrong with continued use. Explore early childhood history of violence through individual therapy once per week. So this is for people who may have trauma and who are interested in recovery. Focus on what kind of role models the client had then and how this affects relationships now. So this would be somebody who has a Dimension 3 emotional, behavioral, cognitive issue needing a mental health strategy. For the next incident of rage and anger, track it, fill in the date, trigger, and physiological signs in your behavior. Then discuss how you could have de-escalated the incident. So this would be a recovery relapse prevention issue around a Dimension 5 relapse, continued use, or continued problem around anger. How are they going to prevent an anger outburst? And then the final strategy example in group, share what has been working to prevent relapse and obtain other suggestions. So again, this is somebody who's ready to embrace a recovery relapse prevention plan and then how they can improve that. Let's see, do we have any questions or comments at this point, Carolyn or Monica?
Hi, David. It looks like we don't have any questions or comments at this time.
Okay, all right. So let me just proceed with another example of a treatment plan. And of course, when we talk about a multidimensional assessment, we would be looking for a problem or a treatment plan that pertains to whatever dimensions are demonstrating functional problems for a person that threaten public safety and that threaten repetitive offending. So here's an example of a person where the problem might be listed as there are assault charges, but the client feels it was a one-time mistake and not alcohol dependence. And then I put in parentheses the clinical thinking about this. Now we can focus on discovering with the client, so this would be a discovery dropout prevention plan, of discovering with the client whether it was a one-time mistake or whether there is more of a problem than he thinks. And this would lead to a relevant goal statement, where the goal statement then would be written as to review previous experience with alcohol and identify if there is an alcohol problem or not. So again, we're giving permission to the client to be honest and to work on a goal to see, can they even agree that there's a problem or not? Because if they don't agree that there's a problem, no good starting to work on a relapse prevention plan for a problem they don't even think that they have. So here's a person who's got assault charges but really feel that it is not alcohol related, when the court and others may think it's definitely alcohol related and they need abstinence and sobriety and recovery. And then some specific strategies would be to review legal, vocational, relationship, and health history and see if it is all squeaky clean with no evidence of an alcohol problem. So, for example, they might go to group and talk about their legal history, their work history, what relationships they've had and whether they lost any of those relationships related to alcohol, and whether there been any physical or mental health problems related to alcohol. And if all of their legal history was just for things like jaywalking and parking fines and nothing to do with alcohol, and if any jobs that they've lost had nothing to do with addiction, and the same with relationships and health, then maybe they don't have a problem. But frequently when people actually delve into all of those things, especially if you have significant other information, then you raise the consciousness of the person that maybe there more of a problem than they think. And then another strategy would be to share what happened in these legal assault charges and share that with group and to get some feedback. Often in group, peers are much more able to see through an arrest and what happened and really are able to raise the consciousness of the client, or maybe an old-timer in recovery in AA thinks and reports to group. In other words, a person might go to an AA meeting and say, here's what happened when I was arrested. What do you think? Do you think that proves I don't have a problem or not? And then their task in treatment would be to go to an AA meeting, some old-timer. They all think I have an alcohol problem just because I got arrested for this. This is what happened. What do you think? And then report that back to group. So these are just examples of a person who, this would be a Dimension 4 readiness to change issue, where they don't think that they have a problem, but you could have similar treatment plans for different issues in different assessment dimensions. All right. Any questions, comments, or disagreements from anybody about how to actualize any of these principles we've been talking about?
It looks like we do have one question.
Okay.
Mr. Nix says, earlier it was stated that the use of graduated sanctions is the key to engagement for treatment. Does incentive-based, strength-based, and motivational interviewing work better?
I think that's a good question, and we talk about sanctions and incentives, and I totally agree that we should be looking to use incentives as much as possible because positive reward usually works better than just punishment. Because, though, the criminal justice system correctly requires there to be consequences and compliance, we can't do away with sanctions, but they should be graduated sanctions for, it's like raising the bottom. It's like what we do when you're working in human resources. If you're a supervisor and you give somebody a verbal warning and then a written warning and then a 1-day suspension and a 3-day suspension, they should be graduated to get the person's attention, saying we can all make a mistake, and so we want to get your attention to do that. So graduated sanctions for evidence that the person is not in good faith doing treatment, not graduated sanctions for poor outcomes in treatment. But the focus on incentives would even be better, or at least hand in hand. And I mentioned this briefly yesterday, but looking for incentives that are not just the fishbowl getting a free gift certificate or a restaurant certificate, not those kinds of incentives. I mean, it's not that we shouldn't do those if they're meaningful to the client, but to look for, in each client, what would be some incentives that a change and improvement in their functional ability would get them things that they now feel are important. So that means asking clients, what would make your life better? If you're assessing their family and they haven't seen their kids and they're estranged from them and they have a restraining order because they've been violent or drinking and drugging, and so the family is scared of them, then a way to engage that person would be, would seeing your kids be meaningful to you? Would that be something you'd like to work towards? And what are you doing that makes people think you should have a restraining order? And how can we work on that in treatment so that you can demonstrate to yourself and to others that there's nothing to be scared of about you? And how are you going to work on the anger and outrage? Or how can you demonstrate to them that you've now got some good quality sobriety? And let's work on intervening and advocating for you to have a supervised visit as a beginning point to build some trust. That would be one incentive that would be directly related to functional improvement. Or another person may say, you know, I'm sick and tired of not having enough money, and I don't want to get money through illegal means. I want to be able to get a job. And I think if I could have some help with my resume, or have some help with paving the way for a job situation, that would be an incentive. How can we then have some incentives that will focus on improvement in functioning to help you to get the sort of job you want, or the kind of housing you want, or the kinds of friends? Somebody may say, I haven't been in a meaningful relationship for years. I'm out of the dating scene. I would like to be able to start dating again. So we're looking at incentives that are tied to their assessment, not just gift certificates and things like that. But absolutely, if we can find incentives, that's much better than just punishment, but there does have to be some sanctions if people are out of compliance with the court mandate to do treatment by demonstrating that they're not adhering to their treatment plan.
Great, thank you, David. And it looks like we have another question from Ms. McNeil. She says, our drug court professionals have been receiving training about individuals impacted with FASD, fetal alcohol spectrum disorders, and have learned that such individuals will likely not respond effectively to level systems. Do you have any info about best practices concerning levels versus benchmarks?
Yes, well, I think this is raising the issue not just for people with cognitive issues and with developmental issues. I mean, I think that can also apply to people with other mental health disorders and even just straight addiction, that not everybody changes in lockstep through phases that are based on time. I mean, if you think about the different combinations of problems a person can have. So when we're talking about fetal alcohol spectrum disorder or other cognitive difficulties or developmental issues or mental health issues, and then even, as I say, in addiction, if we focus the phases much more on functional change benchmarks, then that really is applicable, I think, to all people, not just FASD. But you see it more pronounced when you're talking about FASD or other people, because they don't, they don't change at a pace that can be defined outside of their assessment and just defined in terms of time. That's the whole point of really what we're talking about, is how do we move away from compliance with phases based on time to adherence to real change based on functional benchmarks. So is there information about best practices concerning levels or benchmarks? I think that's where we need to come together with all the stakeholders around, saying what would be evidence that a person can move on from an orientation phase to the next phase. Well, the benchmarks would be, is this a person who's able to complete an assessment, who's able to collaboratively work with a treatment provider to develop an individualized treatment plan? Are they demonstrating the functional ability to understand the treatment plan and work on it? And are they demonstrating active good faith work by showing up regularly, by participating, not just saying the right things, but by actually working on their treatment plan? So, for example, a benchmark of whether you're able to move on would be, is this a person who's actually changing in terms of the 2 or 3 problems that were identified? Say you have a person who has trouble with anger and outbursts, and their treatment plan is the fact that they aren't even sure they have an anger problem, but in group they're going to role play an angry situation with somebody and demonstrate to the group how to handle that in a non-violent, non-aggressive way. Well, a benchmark to whether they can move forward is, are they actually doing that in group, and are they actually demonstrating the ability to handle conflict without being aggressive or violent? Or if you have a person who has a parenting problem, who's ambivalent about whether they have a parenting problem, that might be that in their treatment plan they are to ask in group for a difficult parenting situation, the kid's having tantrums, pulling things off the shelf. Other people would slap their kids, but this person doesn't think they have a parenting problem and are going to demonstrate to the group how to handle that parenting situation in a nonviolent, consistent, but firm way. And if they are working on these kinds of problems and showing improvement in function, that would tell you that they're ready to move to the next phase of coming less to treatment if they don't need so much treatment, or if they don't need to appear at court as often, or, you know, again, it's all based on the treatment plan and improvement in their treatment, not predetermined benchmarks based on time.
David, a question just came in on our listserv, and I thought this might be something that fits in, and it's something I've seen before. It's currently, our program has a participant start their current phase over if they have a missed UA. I am wondering how other programs are handling missed UAs. And I'm going to send it on our listserv, but I just thought this was pretty close to, you know, pretty consistent with what you were talking about in terms of responses. Could you comment on that?
Yeah, so the idea of sort of starting over if you have a missed UA, it's sort of, again, like a rote compliance rule rather than why is the UA missed. That is a poor outcome if somebody misses a UA. And the next step when you have a poor outcome for any illness, and this is, we're talking about people who are getting treatment, if you have a poor outcome for any illness, the next step is to assess what went wrong and how do we change the treatment plan to make it better. So just to give an example, if somebody missed their dose of insulin, or if somebody missed checking their blood sugar level, we wouldn't be talking about rule breaking and having to start some sort of treatment again. You'd say, well, why did you miss your insulin dose? Or why did you not check your blood sugar? Well, you know, I was actually on vacation and I got caught up in, you know, whatever. What's the reason? Or I didn't take this medication as prescribed because I didn't like the side effects, and so let's look at how to change the dose or the medication. If somebody misses a UA, what was the reason they missed it? Was it the fact that they were using and they didn't want to get caught? And so if you were using, how come you were using? And what were the triggers that made you use? And what can we do to help you not succumb to those triggers so that you have to miss a UA? So all of these things should be through the lens of assessing what clinically went wrong, and if the person is willing to change the treatment plan in a positive direction, the consequence, if you want to use that word, but that's a criminal justice word, the treatment adherence issue is then we want to look at how you will adhere to an improved treatment plan to make sure that we give the best chance that this doesn't happen again. And let's understand why things aren't going well, and then assess and develop a new treatment plan for that. So all of these things should not be based on breaking rules, and it should be based on, when they're in treatment, adherence to a treatment plan that is developed on an assessment of what the problem is. Looks like we have another question, do we, Monica? I'm seeing here. It sounds like the individualized benchmarks for each drug court would be best. Was that a comment?
That was just a comment and follow-up to Ms. McNeil's question.
Yeah, I just would emphasize that the individualized benchmarks for each client is really what we should be looking as they move through. So the treatment provider should be able to give concrete examples of how the person is improving such that the public safety is not threatened, and such then that they can move to less intensive levels of care or less frequency of visits, is based on improved function benchmarks, not based on time or phases. Any other comments, disagreements, or questions that we're getting in?
Oh, well, this is just Carolyn again, and I just think that was so important to really bring home to us that not only do we need to have individualized needs assessments, that everyone has different needs, but their pace of recovery and, lapses, I guess they call them, rather than relapses, is going to be different for each person. And it also is geared to the kind of treatment services they're receiving. So it may not always be the client's fault. It may be that they have needs that weren't addressed. So it just, you're bringing home the complexity of all of this, Dr. Mealy, is really very, very helpful.
Yeah, yes, I think you make an important point there, that we often blame the client for a poor outcome, where we might need to look at the treatment match of what we're doing. It might be that we've missed a co-occurring mental disorder, which is contributing to a poor outcome, and missed drug screens or outbursts or whatever. It may be that we need to change the treatment plan, or we might need to change the level of care. But it isn't always increasing the intensity of the level of care if something's not doing well. So I had a patient one time who used while he was in treatment, but he used because he was so excited about the fact that he was doing well with his methamphetamine use that he wanted to share that experience and try to encourage his friends who were still actively using to join him in recovery. But what happened when he visited them and they're still actively using, and he was too early in his recovery, he used with them. And then his counselor said, we have to transfer him from intensive outpatient to a residential. And I said, well, why? Well, because he failed outpatient and he used and relapsed. And I said, well, why did he use? Well, he visited friends who were still actively using, and he was trying to get them to join him in recovery, but he really got overwhelmed with the environment. Well, I said, is he willing to stay away from those friends and not visit them and go to more meetings? Well, yes, he is. Well, then why does he need to go to residential? He can't do that in residential. He can do this more in outpatient. Well, he relapsed. So there's an automatic sort of reflex reaction sometimes that if somebody's not doing well, we have to increase the level of care. Well, not necessarily. You have to change the treatment plan based on what went wrong. And this is really the complexities that treatment providers need to work with. We don't have to expect the court personnel to be skilled in all of these issues. That's outside their scope of practice. But we need to be able to give the court personnel and judges the kind of information that reassures them that real treatment and functional change is happening. And in that hand together sort of collaboration, the court can understand enough whether really good treatment is going on or not. If the court perceives that a treatment provider is just letting a person skate through the program, not really doing change, then the court would correctly have the right to say, I don't have confidence that you're actually doing robust treatment because I don't see any examples you can give me of how this person is functionally changing that reassures me that the public safety is protected. All right. How are we doing? Anything else?
Another question.
Please.
Mr. Kushner says, do you feel that the family of the drug court participant should be assessed and dealt with, not only the drug court participant? Don't we need to focus on the family as well?
Absolutely. In the ASAM criteria, and I'll just bring up the dimensions again for those of you not so familiar, you'll remember that dimension 6 is recovery environment. And in the ASAM criteria, dimensions 4, 5, and 6 are just as important as the first 3 dimensions, which are often thought of as the medical necessity dimensions, that who a person lives with, how a person is being supported financially and emotionally, what the attitude of family members are is as important as assessing all of the other dimensions. So it is critical, in my opinion, that a good treatment provider understands who the person's family is. Now, family may be biological family, but family may be the fact that they are gang invested. You know, they're invested in their gang family. It may be, so in many ways it's asking the client, who do you consider your family? And that may be both the biological family, parents and siblings, but it may also be their emotional family. And why is that important to assess? Because if the family is encouraging or even supporting a person to continue to use and to continue to offend, that's going to greatly impact the outcome of whether we're going to reach the goals that we all want of increased public safety and decrease legal recidivism and crime. And that's a treatment issue. Now, we can't just say, get rid of all your negative friends, as if by declaring it, the person's going to be motivated to do that. If you mandate that, then they're going to say that they're doing it, but not really be doing it. We want them to really be doing it and to work through their ambivalence about things. So assessing the family, if the family is, quote, enabling, meaning that they are subsidizing a person's addiction by letting them stay there without paying rent, or by supporting them even though they're not working, and they're giving them money and emotional support, we need to work with the family to help them understand Al-Anon and other ways to assist and help their loved one. But giving them money or bailing them out all the time may not be the best way for them to show their love and support and actually encourages continued use. So yes, any program where I hear they say we don't really see the family, or they just come for educational groups and so forth, where we haven't done a careful assessment, that greatly impacts whether you're going to get a good outcome if we don't involve the person's family in treatment as well.
And I'll just add, one of the issues we've seen, we've had some contacts from parents of young adults, or adults that have been in drug court, and I think they feel like they've been kind of not involved in the treatment, and so they didn't really, you can tell they kind of were disconnected. They didn't really understand what the disease was of their family member and what the treatment was doing, and what was occurring. Do you think, is it useful to involve the family in actually the review hearings, or giving them progress reports, or somehow involving them in the treatment itself, rather than looking at whether they're enabling it? I mean, maybe that's part of it, but
absolutely. I mean, many families are not. It's just almost universal that they are affected by addiction, and the person's offending and legal problems. That's very painful to most families. And they need education, they need empathy, they need support, they need direction as well about how they can get help both for themselves to deal with their stress. They've often been the recipients of all kinds of, abusive behavior from their loved one, son, daughter, husband, whatever, partner. So they are pained within their own, effects of addiction and legal problems. So not only do they need help for their own recovery, but they also can be helpful in promoting the recovery of their loved ones, and they're involved anyway. So they should, in my opinion, be involved in the court hearings if they wish to be, and to understand what's going on. They definitely should be told what the treatment's about and be included in that and be informed. It would be, to me, it's the same as, say you have a loved one who's getting open heart surgery or having surgery. It would be cruel to have the family be waiting in the waiting room and then never come out and say, surgery went well, they're in the recovery room, here's what happened, this is I mean, imagine somebody having surgery or somebody having a baby and you never talk to the spouse or the partner or the parents. It's the same in addiction treatment. Addiction affects the whole family, and everybody has been affected negatively, usually by the legal problems and the addiction problems, and needs help and should be involved and should not be excluded from understanding what's going on.
Thank you. I think that's very helpful.
It looks like we do have one more question.
Okay.
Mr. Nix says, do you believe that BCA's, behavior chain analysis, are a viable tool for ITP as a response to a treatment plan misstep instead of a standard sanction or violation response, help the individual realize the driver or trigger if there's actual progress?
Yes, so I assume you're saying behavior change analysis like behavior therapy, looking at, antecedents, behaviors, and consequences, or looking at people's thinking and, so a behavioral change analysis is one tool, I think, in terms of assessing what needs to change and whether people are improving. Why I would broaden it beyond just behavioral analysis is that you're also wanting to look at these other aspects in the ASAM criteria dimensions. Do they have a co-occurring mental disorder that needs treatment? Do they have housing and money problems on dimension 6 that is going to affect the outcome? Do they have problems with dealing with cravings? So we're not just talking about thinking errors and criminogenic factors. We're also looking at dimension 2. Do they have a chronic pain problem which is going to affect their outcome and therefore needing to be hooked up and linked with a good quality pain management system? What can often happen in criminal justice clients is that there's been such a focus just on sort of cognitive behavior therapy and behavioral approaches and behavioral models and specific evidence-based practices around criminogenic factors that we lose sight of the whole person and the environment and all these other things as well. So I don't know if I misread your question, but I do agree that a behavioral change analysis is an important part, but you have to look at all aspects of a person's biopsychosocial spiritual being and develop an individualized plan that will give the chance for best outcome. But come back at me if I misunderstood your question. All right, did we get anything more, Monica?
Nope, that looks like that's it.
All right, well, we'll recognize that these will be posted so that if you have other team members who you think it would be useful to listen into these, they are going to be accessible. A reminder that on March 29, we would really welcome any vignettes or dilemmas, either from the court team side or the treatment team side. And if you have little examples of this, so they're not just generic questions, but certain dilemmas about certain situations that come up, or if you have a case that didn't do well that we can help look at and apply these principles to, that you'll be getting notification about how to submit those. And that's for the March 29 at 1 p.m. Eastern. And then a reminder that on April 4 at 1 p.m. Eastern, we'll be talking on engaging participants in a self-change process and looking at individualized treatment based on stages of change and use of evidence-based practices to move people through a self-change process. Any other closing comments from Carolyn?
No,
Yeah.
thank you very much, and thank everyone for all the thoughtful questions you had, and for and Dr. Mealy for your really insightful presentation. As I mentioned when we started, I thought this, and when I first heard you talk about it, it's so common sense, but it's not common sense to those who come from a perspective of the justice system where you expect everything to proceed in the number, in terms of time, days, and so forth that you set out for phase 1 or phase 2 or whatever number of days you need to move on. And from the treatment, which of course makes so much sense, that disease is something that doesn't necessarily proceed in the straight path, and there's so many variables, and we have to figure out how to integrate that with the drug court. So thank you, everybody, and we look forward to hearing your any further questions. Please send them and your challenging cases so that we can talk further on March 29th.
Thank you.
So I hope everybody has